go.
Okay, our next speaker, and people always say last but not least, and so I'm going to say it too. She's last, but it's certainly not the least. And she's been on since the start of the show. But she's also a colleague of mine at Truman Medical Center. Her name is Dr. Sarah Young. She is the pain management pharmacist at our center. She earned her doctorate of pharmacy degree from the University of Missouri in Kansas City School of Pharmacy and completed her postgraduate year 1 at Truman Medical Center. She is a board certified pharmacotherapy specialist and has completed the ASHP Foundation Traineeship in Pain and Palliative Care. Dr. Young's professional areas of interest include pain management, palliative care, internal medicine, and caring for our indigent patient population. She's the co-chair of the Truman Medical Center Corporate Pain Management Committee, is a member of the Palliative Care Team, and is also involved in committees within the pharmacy department. Dr. Young offers a clinical experience rotation for pharmacy students and residents related to pain management and palliative care. And again, as a personal note, she's our go-to person if we have a difficult pain management situation, particularly inpatient, but she's also available to the sickle cell team for any question in general. So I welcome her and thank her for her presentation.
Hello, I'm going to attempt to share my screen. Okay. All right, so let's see, what are you guys seeing? Are you guys seeing the presenter view or are you seeing just the slides?
I think it's just the slides.
Okay, great, thank you.
It looks like the presenter's view.
Oh, okay, okay, hang on, let me.
There, go up to your display settings. In the middle there. There, up, yeah, up top there.
Right here?
See where it says display settings on top.
Oh, I can't see it. There we go. There we go. That's what I was looking for.
Yeah.
Okay, how about now?
Yep.
Okay, thank you. All right. Like Donna said, my name is Sarah Young. I'm a pharmacist at Truman Medical Center. I'm one of the many clinical lead pharmacists, but I specifically deal with pain management and opioid stewardship in our institution. And I thank you, Kevin and Donna, for having me today. I'm going to talk about the medications for sickle cell therapy or sickle cell disease and a couple other things at the end. I'll try to be fast because I know we are running over time and I want to make sure I know what time it is. Okay. And I'm sorry for the animation. I can't make that go away. So we'll just have to deal with that. The objectives for today, by the end of this presentation, we will have discussed the pathophysiology of vaso-occlusive crises, summarize the medication therapies for sickle cell disease, explain the mechanism of action of each medication and how it relates back to the pathophysiology, analyzed literature for decreasing the frequency of vaso-occlusive crisis episodes, and understanding the impact of medication therapy on emergency department encounters. So I know this is probably the third or fourth time we've gone through the pathophysiology of sickle cell disease, so I'll keep it brief. But it's a genetic disease caused from alterations in the beta chain of hemoglobin within red blood cells. And here at the top, it talks about, again, how there is mutation or an alteration in the coding, specifically this GTG, which is a normal code, is replaced with GAG. So instead of having a glutamate, we have a valine. Let's see. At the top here, we'll go ahead and go through all of this because I refer to this picture again later on in the presentation. I want you to be familiar with it. So sickle cell disease has kind of been dichotomized into these two overlapping subphenotypes. So if you go to the left here, you're going to have hemolysis and endothelial dysfunction and damage, which then leads to inflammation and turns into vaso-occlusive crises. If you go starting from the right, you're going to get sickled cells, which turns into vaso-occlusive crises due to basically stickiness and adhesion, which then after so many obstructions within your vessels, you will have reperfusion of the tissue, which sounds like a good thing, but it actually leads to inflammation and further damage, which then, as you guessed, goes back into a vicious cycle of vaso-occlusive crisis. So here is another way of looking at this overlap of subphenotypes. With viscosity, so kind of the thick vaso-occlusion, you're going to have high hemoglobin levels, pain crises, acute chest syndrome, osteonecrosis. And in lower hemoglobin levels, you can have hemolysis, endothelial dysfunction. So you're going to have abnormal labs. You can have pulmonary hypertension, priapism, leg ulcers, possibly stroke. Moving right along into the medications. So hydroxyurea was the only tool in our tool belt for the longest time. Luckily, since then, others have been added, and we will go through each of these in order of their FDA approval. Hydroxyurea was approved a long time ago as a medication, but it was specifically approved for sickle cell disease in 1997. It was approved for use in patients 2 years and older. However, some guidelines and studies recommend use in children less than 2 years of age. Hydroxyurea's mechanism of action, it inhibits ribonucleotide reductase, which is an enzyme involved in transforming ribonucleosides into deoxyribonucleosides, and those serve as building blocks for DNA synthesis. It also increases fetal hemoglobin, which is probably what it's most recognized for. Improves red blood cell deformability, reduces hemolysis, decreases circulating leukocytes and reticulocytes, and reduces the stickiness or that adhesion receptor expression. And then it also donates nitric oxide. I have another image here which shows the mechanism of action in a different way of hydroxyurea for those visual learners. You can see there are both vascular effects and red blood cell effects with hydroxyurea, and you can see how they both play a part in improving tissue oxygenation and decreased inflammation. So hydroxyurea can be used in both hemoglobin SS and hemoglobin S beta 0 thalassemia for decreasing frequency of vaso-occlusive crises, frequency of acute chest syndrome, decreased hospitalizations, decrease red blood cell transfusion requirements, and decrease the risk for stroke. The dosing is anywhere between 15 and 35 milligrams per kilogram, and it's taken by mouth, so it's a pill form. You will never start out right at 35 milligrams per kilogram. You will always titrate up to this dose if needed over several weeks and months. And it is important to always have your blood counts monitored throughout the entire titration period and annually at least. There are dosage adjustments needed if the kidneys are not working as well as normal. And then I've listed some of the most common adverse effects with hydroxyurea, which are myelosuppression, skin hyperpigmentation, nail discoloration, teratogenicity, so you don't want to use it when you're pregnant, decreased sperm counts, nausea, and vomiting. Moving right along into the next medication, several years after hydroxyurea. So Endari, it was approved in 2017 for patients 5 years of age or older. So it is actually L-glutamine, that's the generic, and it is a conditionally essential amino acid. So that means that although the body normally makes sufficient amounts of glutamine, at times of stress, the body's need for glutamine increases, and in such instances, it also relies on dietary glutamine to meet this demand. The mechanism is not completely fully understood for Endari, but it is a precursor for nicotinamide adenine dinucleotide. Usually that comes right off of the tongue, but kind of slipped up on it there. It also reduces oxidative stress. Endari can be used for all genotypes, although it was only studied in hemoglobin SS and hemoglobin S beta 0 thalassemia. It can decrease frequency of vaso-occlusive crises, the frequency of acute chest syndrome, and decrease hospitalizations. The dosing is weight-based, so if you're less than 30 kilograms, you're only going to take 5 grams by mouth twice daily. 30 to 65 kilograms, you take 10 grams twice daily. And then if you're greater than 65 kilograms, you take 15 grams by mouth twice daily. And you can take this with or without hydroxyurea. It is a powder form, and it doesn't, I have never tasted it, but I've read that it doesn't taste very good. So it is unfortunate that it is a powder form. You do mix it with 8 ounces of either cold or room temperature liquid, whether it be water or juice, or you can also put it in 4 to 6 ounces of soft food like applesauce or yogurt or something like that. Most common adverse effects are constipation, nausea, headache, and abdominal pain. Okay, I love this slide. I think it's very exciting for everyone involved in this conference today. The November to Remember. So back in November 2019, it was a very exciting time for sickle cell warriors. FDA approved 2 different sickle cell medications, one being Adaptio and the other being Oxbrida, both to help with complications in sickle cell disease. So we'll start with Adaptio, or crizanlizumab. So like I said, it was approved in 2019 for patients 16 years of age or older. It is a p-selectin antagonist or inhibitor. It decreases adhesion of white blood cells and red blood cells to the endothelium. So as you can see here, this is p-selectin, Adaptio binds to this, and basically it prevents the stickiness, which is going to prevent vaso-occlusive crises. It can be used in all genotypes to decrease the frequency of vaso-occlusive crises. Unfortunately, it is an intravenously infused medication. It runs over 30 minutes, so you don't have to go sit in the clinic for hours. So it's quick. It's just not as appealing to some because it is intravenous. You take it on your first day, and then you'll take it again 2 weeks after that. And then after that, you can just come back every 4 weeks for your infusions. You can use it with or without hydroxyurea. And it was not studied in end-stage renal disease. Most common adverse effects are nausea, arthralgia, back pain, and fever. The SUSTAIN study was how they basically got their FDA approval. And it was a pivotal phase 2, 52-week randomized, multi-center, placebo-controlled, double-blind study. So it was it was a high-quality study. It included 198 patients, ages 16 to 63 years of age with sickle cell disease. The patients were assessed over 1 year or 52 weeks. And the study primarily looked at the annual rate of vaso-occlusive crises in patients. There was a pre-specified non-comparative subgroup analysis about evaluating the rate of vaso-occlusive crisis in patients taking and also not taking hydroxyurea. And then the secondary endpoints were annual rate of days hospitalized, the time to the first vaso-occlusive crisis, and the number of patients who didn't even have a vaso-occlusive crisis in this year-long study. So here are the results of the primary endpoints. On the left here, you see that there was a 45% reduction in the rate of vaso-occlusive crises in patients on Adaptio versus placebo. The results here on the right is that subgroup analysis, but I do want to tell you that you should interpret this with caution because this data was not powered to detect a statistical significance or superiority of Adaptio over placebo. With that being said, a 32% reduction of vaso-occlusive crisis was seen in patients already on hydroxyurea, and then there was a 50% reduction seen in patients that were not on hydroxyurea. This is the results from the secondary endpoints. On the top left here, we've got the median annual rate of days hospitalized, and there was a 42% reduction in those days compared to the placebo group. The middle here shows the time to first vaso-occlusive crisis in months, and there was a difference of 3 times compared to Adaptio and placebo in the days to first vaso-occlusive crisis. And then on the bottom right here, we have the patients who did not experience a vaso-occlusive crisis leading to a healthcare visit during the treatment period. That was 36% of the Adaptio patients compared to 17% of the placebo. Last but not least, Oxbrida. It is an oral medication, and it's designed to increase the oxygen affinity of hemoglobin S and stabilize the oxygenated form of the molecule. It reduces the concentration of deoxygenated hemoglobin S, which is the form of the molecule that polymerizes to give the sickle phenotype, and it also reduces hemolysis. Basically, to put it simply, Oxbrida helps hemoglobin do its job, which is to transport oxygen throughout the body. It can be used in all genotypes to increase hemoglobin. The dose is 1,500 milligrams by mouth daily, with or without hydroxyurea. It was not studied in end-stage renal disease patients that require dialysis. And you do need to have a dose reduction if you have severe liver disease, specifically Child-Pugh class C. Most common adverse effects are headache, diarrhea, and nausea. So the trial that they did for Oxbrida was called the HOPE study. It was a multi-center randomized double-blind placebo-controlled phase 3 trial, including 274 patients aged 12 to 64 years of age. They had 2 different Oxbrida dosages, 1,500 milligrams per day and 900 milligrams per day, and then the placebo group. The primary endpoint was percentage of patients who had a hemoglobin response, which was defined as an increase of greater than 1 gram per deciliter from baseline to 24 weeks. And then the secondary endpoints were the change in hemoglobin levels from baseline at week 24, and the change in laboratory markers associated with hemolysis from baseline to 24 weeks. I will say that the randomization for this trial was stratified by patients already receiving hydroxyurea, geographic region, and also age. And the majority of the patients that they did look at had hemoglobin SS or hemoglobin S beta 0 thalassemia. So here are the results. This waterfall chart is a visual representation of the results. Each bar represents an individual patient and their hemoglobin change from baseline over the 24-week period. The horizontal dotted line here is showing a change of 1 gram per deciliter in hemoglobin. 51% of the patients receiving Oxbrida achieved greater than 1 gram per deciliter increase in hemoglobin compared to baseline versus 7% in the placebo group. And that was statistically significant. Furthermore, 27% of the Oxbrida patients versus 1% of the placebo group had a greater than 2 gram per deciliter increase in hemoglobin as compared to baseline. These are the results of the secondary endpoints, and I'm not going to go through these because I just checked the time and I'm running out of time. So I just know that the secondary endpoints were also statistically significant. Summary and conclusions. So back to this picture that we looked at in the beginning, looking at kind of the sickle cell complications and pathways. Hydroxyurea plays a big role in several of these. As you can see with the arrows, and Dari plays a role with endothelial dysfunction and inflammation. Oxbrida helps up here with the hemoglobin, and then Adaptio is going to help here with the vaso-occlusion and the stickiness. So what's next in sickle cell therapies? The big talk is gene therapy or gene editing. It's still in studies as a possible cure for sickle cell anemia. The approach is based on using host stem cells instead of embryonic stem cells. And these host stem cells are derived by manipulating and reprogramming cells from the patient's own blood cells via genetic engineering. Overall, the approach is used to correct the actual genetic error. These cells will then be eventually regenerated for the entire range of blood cells, red blood cells specifically. In 2017, there was a case report of a 13-year-old boy with hemoglobin SS disease that had been cured with gene therapy. Recent technological breakthroughs are creating opportunities for genetic manipulation through gene insertion, deletion, and modification. And I hope this technology becomes affordable in the future for all sickle cell patients. And then there are other existing drugs and newly developed drugs that continue to be studied for anti-sickling, anti-adhesion, and antioxidant effects. Last but not least, we're all here today because we're talking about the gap with patients in the emergency department. So I wanted to have one slide to kind of tie it all in together. I will only go over this briefly because Dr. Kavanaugh in the beginning did such a wonderful job speaking to most of these points, and I cannot top her presentation. But as a pharmacist, I'm always talking with patients about adherence to their treatment plans, not only their medications, but also just proper follow-up with their providers, monitoring of their labs and adverse effects, and then putting in the effort to understand their disease states and what their treatment plans are aimed to accomplish. All of these things will help to decrease your complications and hopefully decrease the need to go to the emergency department. This leads right into my next point, which is increased patient activation. There was an article titled "Increased Patient Activation is Associated with Fewer Emergency Room Visits and Hospitalizations for Pain in Adults with Sickle Cell Disease." The term patient activation is basically how much knowledge one or a sickle cell patient has about their disease and their capabilities of self-management. Patients that are actively seeking to improve their own knowledge and seeking to identify opportunities for action have shown to have fewer ED encounters. So Dr. Kavanaugh spoke a lot about the need for early and aggressive pain management. Once a patient has actually presented to the ED, the need for individualized care and care plans, and then all of the diagnoses of exclusion, all very important. Lastly, it's most helpful to stick with a team that understands you as the patient or our patients and their history. So sticking with the same institution or the same ED is very helpful for your care, and your primary care physician or your sickle cell physician in helping them control your disease state. It helps overall with better coordination and continuity of care. And I believe that is my last slide. I have tons of references. And what questions do you guys have for me? I'm 1 minute over.
Sarah, I don't have a particular question, but I love the diagram where you show the different new drugs and how they affect the different pathways of disease, and how potentially you might could use them all, just like we have different mechanism of actions for hypertension or diabetes. We may have to use different treatment modalities for our sickle cell patients as well. So I really love that slide. And I appreciate too that last slide where you showed all the different things that involved with decreasing ED visits, and particularly the one about increased patient activation and the role the patient has in, kind of self-advocating and learning about their disease. And then in turn, our responsibility in helping to educate them. So excellent presentation.
Thank you.
That is great. So Donna, I think I will, did you have any questions that came in?
There's been some questions about diet and hydration, and I kind of answered those in the chat.
Okay. So Dr. Young, I do appreciate you taking the time to do this presentation. This has been wonderful. So I think that this is a great way to close out our day today. I will stop the recording. I've got just a small deck of slides that Don and I are going to cover.